here we put together exposure, that's cigarette smoking only, that's on the first line of the table, and they're a reference group. And what do we want to know about those patients? Well, what would you think would be a very impactful if you had a patient in front of you? Would you think that whether they die or not would be important both for you and the patient to figure out? So we looked at the all-cause mortality and the hazard ratio for dying in those patients who had cigarette smoking only, and that's our reference group. So then we compared that to people who had cigarette smoking and abnormal CT scan. You see their all-cause mortality was not any higher. Then we added cigarette smoking and symptoms. Then we defined the group as cigarette smoking plus abnormal spirometry, cigarette smoking plus symptoms plus abnormal CT scan. You can see we progressively added more abnormalities here. And you'll see as we added more abnormalities to the cigarette smoking, our mortality risk markedly increased. So in this intermediate group here, we call this possible COPD. You see the all-cause mortality was about 1.5. Then it rose to 2 or more in the patients we call probable COPD, such as a patient with cigarette smoking, symptoms, and abnormal CT scan, patients with smoking history, symptoms, and abnormal spirometry, or people with all 4 of those together, you see. And patients down here, 5 times the mortality, 5 times the risk of dying than people without this constellation of findings. We call this definite COPD. That is, they have all the features in that graphic to the left. They have cigarette smoking history, they have symptoms, abnormal spirometry, and an abnormal CT scan. Those patients, really, you should think about finding in your practice to be able to figure out what to do with them, cigarette smoking being the most important. Really focus on that, because if these patients stop smoking, we know there's less risk for mortality. Well, we looked not just at risk of dying, but we're interested in what's the progression in terms of their physiologic abnormality, their spirometry. Well, if you think about how much change in FEV1 there should be over time, in healthy people, they lose about 25, maybe 35, maybe sometimes even up to 50 mLs per year. So we said 70 mLs loss of FEV1 per year, or 350 mLs over the 5 years of a follow-up would be very significant change in their spirometry, leading toward classic COPD. So again, smoking history only was our reference group with no COPD. If you add cigarette smoking history plus abnormal CT scan or abnormal symptoms, you have an increased risk of having a marked decline in FEV1. And if you then add symptoms CT scan to cigarette smoking history, or cigarette smoking history plus abnormal spirometry and the CT scan altogether, you see can have at the bottom here almost a 3 times risk of a marked decline in FEV1, physiologic deterioration over 5 years in our definite COPD group. Now, what's interesting here also is that abnormal spirometry was the least important factor associated with decline in FEV1. You can see here exposure plus abnormal spirometry, they really did not have an increased chance of decreasing their FEV1 over time. If you had cigarette smoking and symptoms to abnormal spirometry, they still didn't have a risk of decreasing their FEV1 and progressing their physiologic abnormality over time. So it shows you again that spirometry, we focus on that a lot for diagnosis, but there's things that are more important than spirometry: cigarette smoking history, CT scan abnormalities, and symptoms. So in summary, we've defined COPD gene 2019, a new classification of COPD on the basis of cigarette smoking history, CT scan abnormalities, symptoms of respiratory symptoms, and abnormal spirometry into groups we call no COPD, possible, probable, or definite.